today the main focus is we have to take a message that if there will be a like geriatric fracture, what we are going to do means whether it is a osteosynthesis or it's like a directly THA. So today at the end of the session, our aim is to go with the take-home message. So I think most of the speakers they are mainly specialized in the geriatric fracture. So definitely we'll take a take-home. And now I will take the opportunity to introduce our overseas faculties. And so can I go ahead? So yeah.
Yes.
So first of all, I will take the opportunity to introduce our overseas faculties. And so can I go ahead? So yeah.
Yes.
So first of all, I will take the opportunity to introduce our overseas faculties. And so can I go ahead? So yeah.
Yes.
So first of all, I will take the opportunity to introduce our overseas faculties. And so can I go ahead? So yeah. Yes. So first of all, no, I am getting the same thing repetition of things. So little bit of just.
Sure, you stop your YouTube, which is running in the background. Please stop that.
YouTube does. So I am getting the same thing repetition of things. So little bit.
All other window other than the window other than the Zoom. It seems your YouTube window is open. That's why.
Okay. YouTube does not.
You can go ahead now. You can go ahead.
Yes. Okay. So sharing the PowerPoint. Yeah. Yeah. So now it is visible?
Yes.
Okay. So first of all, I would like to introduce Dr. MEHOOL from UK. He is a trauma surgeon having 25 years of experience, trained in Australia, and he has the honor of winning the most prestigious award of the Trainer of the Year in 2014. And he was appointed as an honorary clinical professor at Anurium Bevan Health Board in 2021. And he is a surgeon, collaborator, and innovator, and has popularized numerous techniques and devices. His strengths include leadership, team building, and training. He is the director at the Sports and Orthopedic Clinic Bristol and has previously served as a treasurer to the Orthopedic Trauma Society UK. Last year, he was awarded a National Clinical Impact Award for his dedicated work for the NHS and Department of Health. He has published numerous articles in peer-reviewed journal, and he is chairman of the European Pelvic Course, one of the leading courses worldwide, and it is appointed and he is appointed as a chairman of the AOPelvic Course. So, Dr. Mehul, welcome to AOPAS and this course. Now, I would like to invite Professor Paul Maria Romans. I had an opportunity to travel to his place in 2019, and he is one of the best, means one of the leading surgeon in the world, I can say, who has done immense research and innovation in the field of geriatric pelvis acetabular surgery. and he was the past chairperson of the AO Trauma Research Commission in 22 to 2024, and in the last period of time, almost he has worked 24 years in the University of Mainz, and he has done immense work in the field of geriatric orthopedic. He has 697 publications in the field of orthopedics. And Dr. Romans, welcome to our webinar. Now, I will welcome Dr. Daniel Wagner. When I was traveling to travel to Mainz, he was there as a consultant in traumatology. Now he is the head of the University Medical College in Lucerne. So he has also done tremendous work in the pelvis acetabular surgery in the field of geriatric pelvis acetabular surgery, and there are many numerous publications to him. And last but not the least, Dr. Michael HERTELEER. He is one of the leading surgeon in Belgium. He is leading the trauma hospital in Leuven, and his main focus is on research, means application of the artificial intelligence and computer assisted surgery in the field of orthopedic. Many biomechanical studies are there. He has almost 37 publications now in the field of orthopedics, and his university ranks one of the best research center in the world in the field of biomechanics. So welcome all, and apart from this, our own masters, Dr. Vivek Tirkha, President AOPAS, and Dr. Pradip NEMADE, our past president, Dr. Ramesh Sen, Dr. Rakesh Rajput, Dr. Samir Agarwal. I welcome all to this evening, and I think let's start to the academic program. Thank you. Over to you, Dr. NEMADE, sir.
Good evening to all.
Yeah.
So we'll start the ball rolling. So I invite the first speaker, Dr. MEHOOL Acharya.
Fantastic. Thank you, everyone. Thank you for the committee for the invitation to be part of this webinar. And I'm going to spend the next 10 to 12 minutes just talking a little bit about geriatric fractures and some of the things that help you decide whether you should fix them or whether we should think about replacing them. And if we're thinking about replacing them, whether we should think about replacing them early, so acute, or delayed. And I'll review some of the literature and my practice. And so I've recently moved. I'm in Nottingham now, which is in the middle of England. So it's in the Midlands, and we're a major trauma centre. We're a university hospital. We have over 1,300 beds. We have a medical school, which has been established for a long period of time. It's really important when we look at these geriatric fractures of the acetabulum, when we think about management and achieving success, we need to understand failure and why we fail and how we need to try and avoid failure. And so if you look at post-traumatic arthritis after acetabular fracture fixation, there are various studies out there, and these are just two of them. So Tile and Jimenez and Joel Mata have all looked at acetabular fractures, and they've shown that about 10% of them fail within the first couple of years. There have been other studies which show that actually 25 to 30% of these patients may require a total hip arthroplasty within 5 to 10 years. And this may even be higher in those patients with poor prognostic fractures. If we look at this long-term study by Joel Mata, up to 20 years of survivorship, even in a very experienced surgeon's hands, there's a 70% survivorship, 79%, almost 80% survivorship at 20 years. So this means that 20% of those fractures are still going on to needing something else, are failing at 20 years. If we look at post-traumatic arthritis and failure, this may well be related to the fracture type itself and the initial displacement. Certain fracture types, if you've got a posterior fracture dislocation with impaction, that might lead to a poor outcome. Certain fracture types in terms of a transverse posterior wall, a T-shaped fracture, posterior column, posterior wall with, again, impaction, these are all poor prognostic fractures. The thing that we can do as surgeons is the quality of reduction. And if the quality of reduction isn't good, then again, this can lead to failure. Age of the patient, so the older the patient, the more likely they are to have comminution, impaction, which again can influence your outcome. And then if we encounter these fractures late, we may have to do more extensile approaches, or we may not be able to achieve anatomical reduction, and hence this may lead to failure. And so there was a systematic review from the UK a couple of years ago, looking at acute versus delayed total hip arthroplasty for acetabular fracture fixation. And they looked at 255 patients. 138 of them had an acute total hip replacement, and 117 of them had a delayed total hip replacement after fixation. And what this systematic review showed is that there was no difference in functional outcome or complication rate between those two groups. However, there was a significant difference in the revision rate between the two groups. And there was a much higher revision rate, 7.1, in the delayed group versus 4.3 in the acute group. And so a total hip arthroplasty in the acute setting for acetabular fracture may well be an option for a specific group of patients. This is what I do. This is my technique. And so I'll think about using one or two approaches for acetabular fracture fixation. I will approximate the columns, the anterior and the posterior columns and the walls. And these are easier to realign when the femoral head has been removed. You can see the reduction. And then I use the femoral head as autograft to fill any voids or defects. And then once I've stabilized the columns and the walls, I can use a hemispherical cup or other techniques as a circular plate inside the acetabulum. So the key concepts really for me for an acute total hip replacement are stability of the columns, stability of the implants. I want to allow the patient immediate weight bearing. And in the younger patients, so the 65, 70-year-olds, I want to try and restore their bone stock, because these are the patients that might live another 15, 20 years and may need a revision afterwards. And there are lots of ways of achieving this. So if the potential problems with an acute total hip replacement in acetabular fractures is that it is a more extensive procedure. You think there may well be an increased risk of infection and blood requirements. Sometimes it can be a challenge to try and position and stabilize the cup, and you need to be aware of complex revision hip techniques. There's a risk of leaving the patient with abnormal biomechanics and a risk of leg length discrepancy and a risk of potential dislocation. These are just some of my cases, some of the ways you can try and reconstruct the acetabulum and the hip. So it goes through from a jumbo cup with lots of screws and then a cemented hip inside to an anterior column screw, posterior column plates and a total hip replacement, fixation of the anterior column through the AIP approach, and then a separate incision for the hip replacement, and then using revision type implants, so augments and cones to try and reconstruct the acetabular fracture. And so again, going back to the key concepts, for me, if the anterior column is broken, then I'd be keen to try and stabilize that. If the posterior column is broken, then I'd be keen to stabilize that. And then what I'd do is I'd use a revision hip, a revision shell with multiple screws as an internal plate, and put in a total hip replacement. So we looked at our results, and we've been doing this for between 25 and 28 years. And Tony Ward, one of our senior surgeons, started this in the late 90s. So we looked at our results, and we looked at our midterm results of complex acetabular fractures treated with an acute total hip replacement. We had 77 patients who had complete follow-up in just over 50. 15 of those patients that were lost to follow-up had died. So we had mean follow-up of 5 years, up to 12 years. Our mean age was 67, ranged between 42 and 90. And the 42-year-old was a transfer from Greece who came back to us 6 or 7 weeks after an acetabular fracture. So that patient went on to have a total hip replacement. Median time to surgery was 9 days, and we had a 9% complication rate. This is the Kaplan-Meier survival curve for our patients over that 12-year period. And you can see that we have a 90% survival at 12 years. If you look at the Oxford hip score for our patients, the majority have an Oxford hip score of between 40 and 48, which denotes a well-functioning hip. If we look at the literature for acute total hip arthroplasty, there are lots of studies out there. Ours is the current study, the one right at the bottom, and that has the highest number of patients enrolled into the study, and it has one of the longest follow-ups as well. So I'm just going to go through a few cases and a few different ways of trying to reconstruct the acetabulum when you have an acetabular fracture. And these are some of the techniques that I use. So the first patient is a 70-year-old female who's got severe rheumatoid arthritis, pulmonary fibrosis, Sjogren syndrome, so Sika syndrome, and hypertension. And this patient has had a previous pelvic fracture. They have had that fracture treated conservatively. And then the patient has a further fall and now has pain in the left hip and is unable to weight bear. And you can see the two x-rays, and it's subtle, but you can see the difference that subsequent to the new fall, there is some impaction of the left acetabulum in the dome region. So what do we do with this? Do we treat it non-operatively? Do we think about trying to fix it percutaneously? Do we think about doing something else? And how do we weight bear this patient? Well, before we have a decision to decide on some of these things, this is what happens. So this is 10 days later. Same patient has further pain and therefore has a further x-ray. And so now we're pushed into a situation where the patient was mobilizing pretty independently beforehand, now has this acute fracture, and we need to think about what we need to do. And so for me, my plan was to do this and treat it as a fix and replace, all through one single approach. So a Cocker-Langenbeck approach, thinking about stabilizing that posterior column with a posterior column plate, using the femoral head as an allograft, and you can see where I've impacted that femoral head into the defect, and then stabilizing that allograft with an anterior column screw, and then using a multi-hole shell internally as a plate with multiple screws to put in a total hip replacement. So these are the post-operative images of that patient, and you can see that we've restored the biomechanics, we've restored the offset, restored the length, and filled that acetabular defect. And this is that patient 8 years post-op. So you see that the bone graft has incorporated and the patient's doing well. A second case, so this is a much older patient, so an 86-year-old female now, who again is walking independently. She walks up to 5 miles a day, and she had a fall from a standing height. So she's got a significantly displaced right acetabular fracture with marked comminution and a protrusio of that femoral head. Some CT scans just to show that fracture in a little bit more detail. And you can see there's some impaction in the dome region as well. You can see that her iliac or the sciatic buttress and that iliac corridor is intact. So this is a low ABC type fracture. Again, some further cuts through the axial CT. So what do we do for this patient? Do we treat conservatively? Do we treat it with a fix and replace? Do we treat it with just fixation? And if we're thinking about any of these, is it a single approach? Is it a dual approach? And so the aims for me are to allow the patient to sit up and to sit out, to help with their pain, and to allow them to weight bear as soon as possible. And so this was my plan. So again, a lateral position. I use a bean bag or a suction bag, which I can x-ray through, an extended Coquelange-Beck approach. And I'm thinking about plating the posterior column and then inserting a tumor-type prosthesis, a cone hemipelvis, to reconstruct the hip. And so these are some intraoperative images, and you can see that I have inserted my wire into and along that sciatic buttress into that ilium along the LC2 corridor, and I've confirmed the position with image. I've then created the channel for the stem of that cone prosthesis to sit. I've reduced and fixed the posterior column with plates and screws, and then I've cemented in a dual mobility total hip replacement. So these are the post-op images. And again, you can see that we've managed to recreate the biomechanics. We've recreated the offset, recreated the length, and we've allowed fully weight bearing. Oops, excuse me. And that's the patient 3 years post-op, mobilizing pain-free. Case number 3 and final case. So this now is a 76-year-old male. So this is an intermediately aged patient. The first one was 70, second one was 86, and this is a patient somewhere in between. So again, fit and well, hypertension, but cycles a lot. And he has sustained, he's come off his bicycle, he's got a left displaced comminuted acetabular fracture with significant dome involvement and impaction. Some view day views for him, just showing that degree of comminution, the degree of dome involvement and impaction. And some CT scans, again, just to show what we've already talked about in the x-rays. So for him, he's the younger patient, and for him, I want to try and restore his bone stock. I want to restore his anatomy, because he's the gentleman that may live another 15, 20 years and may need a revision hip replacement. So for him, I'm thinking of a dual approach, an anterior intrapelvic approach to reduce and fix the anterior component of that acetabular fracture. And I've stabilized it with a pre-contoured IAP plating system. And this is what the AP and the Jude views look like. You can see the anterior column looks good, but there's still that impaction of the dome. There's still that displacement posteriorly. And so then I turn him, I fix the posterior column and stabilize that. And then I put in a total hip replacement. And these are the post-ops for him. So he came back to clinic a couple of months ago, and at 8 weeks, he was off his crutches and he was back to driving. So in summary, for me and all of us, elderly osteoporotic acetabular fractures are increasing rapidly, and they will continue to keep increasing. It has been projected that these will increase by 30% by 2030. And so these are a challenging group of patients. They find it very difficult to non-weight bear. And we know that with the comminution, with the dome involvement and dome impaction, if we fix these, they are likely to have higher failure rates. And so acute total hip replacement for acetabular fractures, for me, can provide a very good solution with early good to midterm results in specific groups of patients. So those with the poor prognostic fracture types, those that are elderly with osteoporosis, but fit for an operation, or those that have delayed presentation of acetabular fractures. And currently we're just looking at our longer term data, our 10 to 15 year data, which hopefully will come out in the literature later on this year. Thank you so much.
Yeah. Thank you, Dr. Mehul. I think most of the things covered. Any question, or we'll take it later after the all the 6. I think it will be better to take all the questions at the end of the presentation. Tirkha sir?
Yeah, so Kishore, we can move on to the next talk. We will have I'll request all the participants to write down in the chat box if they have any questions, which can be taken up later by all the faculties while we continue with the talks, and then we can have a discussion right in the end of it.
Yes, few talks are maybe overlapping, so it is better to take all the question at the last, I think. So I will invite the next speaker, Dr. Daniel, to speak about the osteosynthesis and the downside of the primary replacement, acute replacement. Yeah. Yes, it is visible. It is visible.
No, you hear me now?
Yeah, we can hear you.
Perfect.
Perfect.
Okay. So first of all, thanks a lot for the invitation to this symposium. It's an honor for me to talk here about what we all share as passion. First, I want to talk a little bit about osteoporosis. It was possible for me to visit Ganga Hospital, and I have seen you care a lot about high energy trauma, and in Europe, osteoporosis is the big subject. So we see if it also concerns India. We talk about non-operative treatment, why we should try to do ORIF, when, and what I have tips for reconstruction of acetabular fractures in elderly. So we see in Europe in the next years augmentation of 30% of our old people more than 65 years, and with that comes osteoporotic fractures augmenting 40% in the next years. So how about India? India is growing in population, and I have seen that also in India, population over 50 years will grow in the next years of 1/3, and you will have osteoporotic patients or people, not patients, from 21 million some 10 years ago to 108 million. So this is an increase of 750%. So it will be also a big concern, I think, in your patient group, the osteoporotic patients. So when we talk about non-operative or operative treatment in elderly, everybody says that the publications of Judet and Letournel talked about not operating these people. However, when we look at the publication from 81 and then also from 93, they talk that what kind of fractures they had, anterior fractures, and treatment was almost always surgical. Publication of 81 and then the book of 93, the same result. So it is not an exclusion criteria according to Letournel to operate on elderly. Non-operative treatment seems easy and safe. However, in these elderly people, also they have 30% of unacceptable, poor functional result, and even with traction, which usually doesn't work in these fractures to reduce the fractures, they have secondary displacement. This was already published in 89. What is the outcome of non-operative treatment? In a meta-analysis, they showed a lower mortality. Yeah. They showed a lower mortality, a lower conversion rate to total hip arthroplasty, and lower complications than the reconstruction. However, in all these studies, they were looking the indications and the displacement of these fractures are not clearly defined, and so I think it's very hard to compare different fractures if we don't know about the indications for non-operative treatment. And when we look a little bit better at results, what is about the function? Good function with a WOMAC of 13 or an SF8 of 51, which is not at all a good function. So I think non-operative treatment in the functional sense of way is not the way to go. In this elderly, this is a study from Grenoble. They took 82 patients, 44, so about the half was treated non-operatively. Anterior fractures were treated operatively with reconstructions, posterior fractures with total hip replacement. And they have shown that non-operative treatment had lower Harris hip score, lower Parker mobility score, lower autonomy, lower blood, of course, lower blood transfusion, and a higher mortality. So we see that this treatment does not work in the side of function nor mortality, and also this, if it seems safe, has 50% of complications, so a very high rate. And what is about how to do it? Often it is recommended, as here from Ireland, to do protected weight bearing. And also with protected weight bearing, only 14 to 30% had their articular congruence maintained as before, but they come to the result that conservative management should continue to play an important role in these fractures. When I treat patients in this age group, old and frail, my goal is to have them mobilized, because we know mobilization avoids complication and makes, as you see this old lady, our patients happy. We know from proximal femur fractures that the better they're mobilized, the lower their mortality rate is, and the lower their complication rate is. And what about non or protected weight bearing? We know it is not possible in elderly to do non or protected weight bearing, or they do not at all weight bear and stay in bed or in wheelchair, or they do full weight bear. And this is our goal that we have to aim. And what about mortality? Mortality in non-operative treatment is higher than in operative treatment. This was shown in multiple studies. So it is not a safe way to go in elderly. This was a publication recently this year from France, 94 patients, multicentric, no, not multicentric, from Dijon, and they showed, they compared non-operative treatment, reconstruction, fix and replace. They did let non-operative treated patient non-weight bear for 6 weeks with reintervention or intervention rate of 28% and a survival which was lower than the reconstructed patients. Reconstructed patients had the best survival, they had a good function, they had a low complication rate in this group, and a conversion to hip replacement in 11%. And in this group, fix and replace patient had a higher mortality than reconstructed patients with osteosynthesis and a higher complication rate. So for me, non-operative treatment is only possible if weight reconstruction, or I'm sorry, to conclude, often it is recommended to weight restrict, which is not possible. People talk about secondary congruence, but often it leads to secondary incongruence, and they have a worse function, worse survival, and more complications. So non-operative treatment for me is indicated in non-displaced fractures when the fracture is as stable that I can allow patient to weight bear fully, and in patients where we introduce a palliative care where only analgesic without any mobilization is the goal. When we talk about fractures in elderly, we see that more than half of them consist of anterior column fractures, both column fractures, or anterior column and posterior hemitransverse fractures. Why is that? We have a femoral anteversion, and when people fall on their hip, the force is transmitted from the trochanter in the anteversion femoral neck to the anterior column, which pushes this away, breaks the connection between anterior column and posterior column, and then rotates the posterior column inside, which is the typical image we see in anterior column, posterior hemitransverse, or both column fractures in elderly. So this also reflects then how people operate. We see here a survey from active OTA members, so experienced surgeons where modified stopper is used in 50% and modified or classic ilioinguinal in the rest of the patients, of the surgeons. And now the young surgeons mostly use modified stopper or intrapelvic approaches to, I think, mostly address these fractures. If we compare acute total hip with or without osteosynthesis or osteosynthesis alone, we see often that they have a better functional outcome, less complications, less reoperations, 10 to 30% more, but more dislocations. However, there were also studies showing a high rate of loosening of 41% at 10 years. And we know on the other side that if we do open reduction and internal fixation, we have a secondary total hip arthroplasty from 0 to 50%. In the most studies, it's around 20%. So this is an example of a patient with an anterior column and posterior hemitransverse fractures, which was fixed like that. And we saw we have a nice congruent joint with the joint lateralized. However, we see at 6 months that the joint medializes, that the dome, which was reduced, displaced in this elderly patient. So what is our problem? Our problem is we don't know how to select patients for replacement or reconstruction. If we go to the literature, we see here in 90 patients where 30 patients had a change to total hip arthroplasty in 5 years and 7 a loss of reduction, that the risk was marginal impaction, comminution, and poor reduction. In 40% of the patient, the reduction was fair to poor, according to criteria. And we know that if we have negative predictors, as in this study, marginal impaction, femoral head injury, or posterior wall involvement, we have a better outcome if we do an acute total hip, in this study with osteosynthesis combined. Another study showed in 78 patients, 40% had a change in 5 years to a total hip arthroplasty, and in total also those without change, 1/3 had poor outcomes, and the risk for poor outcome was non-anatomical reduction, which was more often by column fractures and in low energy fractures, and another risk was female gender or osteoporosis. So we all learned the Gauss sign. However, the Gauss sign is not always a Gauss sign. When we talk about the dome impaction, Gauss sign means that we have an impacted fragment, as you see below here, which is possible to distinguish from displaced fragments with this zone of condensed bone, which was called by Bastian this year as brick sign. So we have a condensed zone around the impacted fragment. Whereas if we have a displaced fragment, usually from the anterior column, it also looks like a Gauss sign. But if you have a good look at the CT scan, you see it's a fragment who is displaced and it's not an impacted fragment, which is reconstructible. And on the other side, dome impaction, we know that this is a negative predictor and may lead us to another conclusion for treatment. So be aware of negative predictors for osteosynthesis, which are dome impaction, non-anatomical reconstruction, posterior wall involvement, and femoral head injury. When we want to stabilize a fracture after reduction, to maintain the reduction, we see in the last years that medial buttressing became more and more important. However, we see in 2 biomechanical studies, this one is from the group of Bern, they showed that if we have long screws like this here, connecting the anterior and posterior column, so the infraacetabular screw and the posterior column screw, we have the best biomechanical results, better than with medial buttressing. This is another study which showed the same effect of posterior column screws. And so the concept is not only to buttress from medial, but especially to close the acetabulum and to do a stable triangle with the infraacetabular screw connecting the anterior and posterior column with the posterior column screw and the connecting plate. So I have a triangle and the head cannot medialize, which was done in this case by Professor Rommels. This is a case from Mainz. However, we saw more and more in this elderly patient that it is not enough to stabilize the column, that we still have a medializing effect with osteoarthritis following. And so I think long screws to connect the columns are important. However, in elderly, without having a proof from research, medial buttress may be helpful to hinder secondary displacement. Maybe this is due to the rotating effect of the posterior column, which is not as easy controllable with screws connecting the columns. So when I address these anterior fractures, I do use long screws to connect infracetabulary, here with the fossa screw, the anterior and the posterior column. I try to support the articulation with screws above the articulation and then to do posterior column screw additionally, which is not possible to stop approach. I use the pararectus approach, and you see in this case the posterior column screw were also not long enough, so it's very difficult also from the pararectus approach to connect the anterior and the posterior column with the posterior column screw. So this is a case in a 69-year-old patient with a posterior column and a posterior wall injury, multifragmentary, and we decided with the patient to reconstruct. The reconstruction after 11 months seems to work. She does not have any osteoarthritis. However, another problem showed here she had a non-union, which was then addressed with this kind of osteosynthesis from the trochanter osteotomy. To conclude, osteoporotic fractures challenge and will challenge all of us more and more. Non-operative treatment only in stable and non-displaced fracture where a patient can fully weight bear. Negative predictors usually are a contraindication to reconstruction. However, as you saw in the last case I showed you, sometimes individual decisions may diverge from that. You have to differentiate dome impaction and dome displacement. If you have a displaced fragment, this does not mean a negative predictor. However, dome impaction is a negative predictor. Use long screw and medial buttress if possible. Thank you very much for your attention.
Yeah, thank you, Daniel, for such a nice review of literature, and most of the things have been clear. I think Dr. Krishna Kiran, it will be late. Okay. So now the next speaker is Dr. Michael. Yes. So you can go ahead. So his talk is when he will do replacements. What is the logic behind his replacement? I think almost 40-50% have been covered. So Dr. Michael, go ahead.
Yes, thank you for this invitation, and also thank you to the previous speakers for giving a very good introduction to the subject that I will cover, as parts will overlap. Unfortunately, they overlap where I expected, so I left them out so we can have a more technical discussion. But just to say briefly, I have nothing to disclose regarding to this talk. If we look at pelvic and acetabular fractures in Belgium, also here you see that the majority of our patients are elderly patients who suffer from osteoporosis, as Daniel already mentioned in his talk. So the problem is very real for us, but the solutions are less clear. So as already said, these patients have a lower muscle mass at admission, and they experience more complications due to immobilization. And so that's why we want them to weight bear early. We want to have as little complications as possible, and preferably in one surgery. And so the acute total hip replacement or the fix and replace seems like a surgery that could solve all those issues. So when it comes to acetabular fractures, as already talked about by Dr. Mess. He said that there are some poor prognostic factors, and those poor prognostic factors, yeah, they become more important in the elderly because preferably we would only want to do one hip replacement and not end up in a complex revision cycle. And so the poor prognostic factors are the gull sign or the roof impaction. On the side, I'm not sure if I fully agree with the publication of Johannes Bastian, because I think that there is still a third type, which is something in between, where due to the osteoporosis, there is an impaction of the subchondral bone and the entire brick part that places up. That's something that we are looking into, and that new technologies like photon counting CT might be able to show us. And so I think the idea is in the right way, but the publication is not complete. And then, of course, there are all the factors that influence the cartilage, and like the femoral head impaction fractures. Those are devastating for the cartilage. A hip dislocation is also a serious injury to the cartilage. If there's osteoarthritis, there is already damage to the cartilage, and Pipkin fractures also fractures with a lot of damage to the cartilage, and also posterior wall impaction, which also have severe damage to the cartilage. So even, I think, and that's the general idea, is that when you manage to reconstruct them and reduce them anatomical, the damage to the cartilage, which you don't always necessarily see on a normal postoperative CT scan, you would actually have to do an arthro CT scan to assess the damage to the cartilage. That is probably the problem, and we can't properly diagnose the cartilage damage before the surgery. During the surgery, if we would do a surgical hip dislocation, we could, but that's maybe a bit too much in the elder patients as well. So when we think about cup stability, when we want to replace the cup in the acetabulum, the school in which I was brought up always talked about it. For a stable fixation, you need a 3-point bony support. So mainly you need to have a stable iliac, a stable ischium, stable pubic bone, and most importantly, the acetabular fovea does not provide any functional support of the femoral head or endoprosthetic socket. One of the ideas is also that with evolution, it actually might actually become a hole and is not filled with bone. When we talk about revision surgery, this 3-point fixation concept might be a bit too limited to stable a cup, but definitely those are the most important parts of bone that you want to be stable in order to have a press fit of your cup if you choose a regular or a revision cup for your replacement. This image shows again which are the most important areas: the spherical spine, the pubic tubercle, the ischium, and also the posterior column, actually. And again, the column concept was already brought up, but it is an important concept, and it brings us back to that idea each time we think about fixing acetabular fractures, but also when we think about hip and replace. So these are the parts of the image in the by Manson, shown on the image of Latournelle. But the column stability is the most important, and this was also very nicely described in a publication by Mark Rickman, where his workhorse to do this procedure was an anterior column plate and a posterior column plate to restore the columns and then place a cup in there. So in general, the idea is relatively simple. You want to restore the 2 columns, and mainly you want to preserve bone stock. When you handle osteoporotic bone, the main thing is that you have to be gentle. Screws, if you drill screws, you usually only have one chance or they will break out. One of the things that I personally regularly do is I drill with small fragment drills, but I place large fragment screws in order to have as much purchase of the screws as possible. I think in these cases there is a place for the use of angular stable screws in pelvic cases, although a lot of people say angular stable screws are not necessary to treat acetabular fractures. But if you want to then place a press fit cup, I think the angular stability in a plate might give you just that extra bit you need. Because if your cup is unstable, it will come loose. And you will be as sad as a young child that saw his ice cream fall on the floor. So the approach is already discussed by Daniel. For anteriorly, we can use anterior approaches in the younger generation of surgeons. It's mainly the AIP approach. For myself, also the pararectus approach is the main workhorse, because it allows me to see the entire anterior column and place the screws maximally in the strong bones. If you want to place screws posteriorly towards the ischium, that is much more challenging from the AIP than from the pararectus approach, in my opinion. And for posterior approaches, the Coker-Langenbeck is a classical workhorse. For some specific cases, the iliofemoral approach that you can extend into the direct anterior approach of the hip interval is useful. This is also known as the Levine approach. I will show you later in a case how it looks like. And so you have to be very flexible in your mind to think what is the most tailored approach to treat the patient. And so it requires a lot of expertise. And me, myself, when I doubt, because I'm mainly a fracture surgeon, I do hip arthroplasty as well. But whenever I doubt or I foresee difficulties, I always contact my revision hip arthroplasty colleagues in advance, because I know that they will have more experience in the placement of a difficult cup and gaining adequate stability. So the literature was already extensively discussed, so I will go over it. I will skip this slide and go straight to the cases. So here we see a 79-year-old man, low energy fall. He has atrial fibrillation. He has Parkinson's disease, colitis, so he's not in great general health. You see that the femoral head is dislocated through the hip joint, and it also seems that there is an impaction of the dome. When we look at the 3D reconstructions, we can see the displacement, and personally I would describe this as an anterior wall fracture or a very low anterior column fracture. In order to solve this, we did a pararectus approach and placed a medial buttress plate, and then went on through a direct anterior approach, which was unfortunately complicated by a fracture in the trochanter, which is a known problem of the direct anterior approach in elderly patients. But nevertheless, it is a muscle sparing approach that can be done with a less big skin incision, and a trabecular, not a trabecular metal, but a rough cup was placed and screws were placed through the cup. This patient was allowed to walk to weight bear immediately. And another case was a 77-year-old man who fell off his race bike. So it means that he's healthy. Again, a gull sign, an impaction of the dome, prognostically not a good factor. Also, the posterior column was displaced in this case, so I would classify it as an anterior column posterior hemitransverse. It's an incomplete anterior column fracture. And so we did a pararectus approach and buttressed it without aiming even for anatomical reduction. And as Daniel already said, placing posterior column screws can be very challenging. And in this case, we did not achieve to do it. And because in this case, the posterior column screw needs to go all the way to the ischium, which is very far and very challenging to do that, especially without a navigating instrument. This was early on in my career, this case. And I managed to solve it with a larger size cup to gain stability. It was more difficult to get cup stability because I think because of the ischium that was loose, that was not completely fixed, but nevertheless, with the use of a few good screws, the cup was stable in the bone. Another case was a 72-year-old man who fell from his roof. He was in good general health, and he sustained a very atypical anterior wall fracture, where basically the anterior superior iliac spine was detached from the front of the ilium, with also a cartilage impaction of the dome. So difficult to get a good outcome and get a good to do a good fixation that will be good for the rest of his life. So in this case, I decided to do the Levine approach, which is you open up the first window of the ilioinguinal approach and you extend it into the direct anterior approach. When you detach the inguinal ligament from the anterior superior iliac spine, this will give you an extensive view of the anterior wall and the upper part of the anterior column. So this was then temporarily fixed with screws and a small spring plate on top of the acetabulum in order to push the remaining bone down so that we would have a good bone stock. This is how that looks like more or less in the surgery. So this here is the top of the iliac crest, anterior superior iliac spine. This is the normal interval of the direct anterior approach. This was the skin incision if you would completely follow it. I think in the end I made the curve a little bit less strong, but nevertheless this was the way it was described by the group of Joel Mata et al. And as you can see, you have in this way a complete view into the acetabular socket. And this is, if you would put a retractor here, then you would have a full view into the ilium, and you can address the fracture perfectly. We then placed again a porous cup with screws, which was uncomplicated. Because this was also a case from in the beginning of my career, I was still unsure about how much shall I let these patients weight bear? Do I allow them to fully weight bear, or do I restrict them? And the guy was in good health. So I said, okay, plantar touch. I'm not sure if he did it, but nevertheless, everything went fine and he's very happy. So a 70-year-old woman, a bike versus a
Sorry to
car.
interrupt. Can you just move on with cases because we are running late? So can you
Okay.
just move on with yeah.
Yeah. So in the end, you have different solutions as well. Some circlage wiring is also described technique. The iliac wing cup has been discussed. Cup and cage constructs, as described by Krappinger, are also definitely useful and interesting concepts. So the main take-home messages that I wanted to give you, that it is important to identify the bad prognostic factors, that you have to think about restoring the columns, and that you have to be very gentle with the reamer. Yeah, that it is not like reaming in an osteoarthritis case where the bone is very hard and sclerotic. No, you have to be gentle, because if you push too hard, you will just go through it. In doubt, just don't be afraid to work together with revision arthroplasty colleagues. This is very challenging surgeries, and we just want a good outcome. Nobody has a very high volume of cases, so it's good to bring together expertise. And I do think that it's important to aim for early full weight bearing. Thank you.
So thank you. It was a nice talk. So I invite now Dr. Krishna Kiran. He is getting late. So Dr. Krishna Kiran, you can present.
Thanks, Kishore. I apologize. I have to rush somewhere for an urgent family commitment. So I was asked to talk about acute acetabular fracture implant selection tips and tricks. Most of the talk has already been covered by the previous talk, so I will stick to certain points which have been omitted in the previous speakers' presentations. So we have seen that hip arthroplasty following acetabular fractures can be in acute setting, failed conservative treatment or failed operative treatment. And the THR for acute acetabular fracture is indicated in fracture types associated with poor outcome after ORIF, which have already been discussed. Sometimes in pre-existing osteoarthritis in an elderly patient with medical comorbidities and obesity as well, we need to look at this as an option. For fracture neck femur, everybody says that you must get the patient out of bed. Otherwise, the 1 month mortality is 30% and 1 year mortality is 50%. But surprisingly, for acetabular fractures in geriatric, nobody looks at the same argument. So I think the same argument holds true. We must fix this or replace this along with fixation so that we allow them to weight bear as soon as possible and get out of bed. Otherwise, the mortality rates will be similar to that of a fracture neck or femur. And we also looked at the results of acetabular fractures in elderly. There's a high failure rate in more than 55-year-olds as early as 3 to 4 years following surgery. And poor prognosis is seen with T-shaped fractures with posterior wall, with more than 5 days delay in associated fractures and more than 3 weeks of delay in simple fractures. So the key objective in a acetabular fracture is to achieve a stable construct rather than an anatomical reconstruction, and it must be so stable that you must allow weight bearing. And the key challenge is to achieve simultaneous stability of acetabular fracture as well as socket fixation. Now, if you look at the acetabulum functions like a keystone, and the connection between the anterior and posterior columns assumes importance, and this is not usually present in a fractured situation. So you may have an anterior or a posterior column insufficiency and the keystone is disrupted, and therefore you will not be able to achieve a stable socket fixation in some of these cases with segmental fractures of the posterior or anterior columns. And here fixation into the ilium, ischium and pubis, all the 3 quadrants becomes critical, and all the principles of revision surgery must be followed in order to achieve good outcomes in these patients. Careful preoperative planning with CT scans. You must have implants to fix the acetabulum, higher porosity cups, augments and cages must be kept in hand. These are some of the anterior protrusor rings or cages, but the cornerstone for managing these cases nowadays is to use higher porosity surfaces like trabecular metal or gription or some sort of a stick tight type of coating. And we must also have cups which have got peripheral screws rather than the standard cups so that you can engage the superior pubic ramus and ischium. The key concepts are discontinuity must be plated, anterior wall and column must be restored, and you must use multi-hole highly porous socket with cage. Keep an option of dual mobility, and inferior fixation becomes important for success. You must identify the corridors for fixation, and you must identify these 5 screw corridors in order to optimize the stability in these sort of situations. The location of the pubis and the ischium makes it difficult for us to use standard sockets which are available in the market, and this requires the use of special sockets like the REDAPT or the T-MARS, which have got more peripherally located screw holes in the inferior position to engage the superior pubic ramus and ischium, which I believe becomes an important component of stabilizing these fractures. And you can combine this with a cemented dual mobility cup to reduce the risk of instability. So utilizing this hybrid principle of achieving stability of the columns through plating, using an implant with higher porosity with option for inferior fixation into the pubic ramus and ischium with the use of a cemented socket which locks this entire construct down becomes the way forward for managing these sort of cases. The key tips for acetabulum: how do you size this acetabulum? As Michael was pointing out, you must ream on reverse, not ream on the forward in these cases. And once the walls or columns are fixed, and when you ream on reverse, once you reach the correct AP size of that particular socket, the reamer will disengage. That is how the reamers are made. So once the reamer disengages, now you know that this is the size of the socket. And one of the important causes of failure in these sort of fracture situations is undersizing of the acetabular socket. Second way to identify is to measure the head size when you retrieve the head, and the socket is usually 3 to 5 millimeters larger, and if acetabular situations are there, then you must look at a socket which is 6 to 7 millimeters larger than the native femoral head. How do you know whether you have reached AP capture or not? You put in your trial and rotate the cup, and you find that you are unable to rotate the cup. And that indicates that the AP size of that particular socket is adequate. And now the third point of fixation needs to be achieved either through screw fixation, or if you are lucky, you are able to get a good peripheral fit through the porous cup itself, then the toggle will become negative. And as I told you, the fixation into the ilium, ischium and pubis, identifying all the 5 screw corridors for the acetabular cup fixation becomes critical. So you can sometimes have a bailout option like this. You can have a Schneider cage with a cemented cup. You can have the coated cages like the MRP Titan, or you could have the cone processes, which has elegantly be shown by Dr. Ms. Acharya. So these are a couple of case examples. You can see a case with dome impaction, elderly lady, 79-year-old, who presented 2 weeks after the injury. And you can see on the CT scan as well that there is a dome impaction in this particular case with an anterior column injury. And this is the intraoperative picture showing plating of the acetabulum and restoration of the column continuity. And then you use a hemispherical socket with fixation into multiple zones in order to achieve immediate stability to allow weight bearing for this particular patient. Now, when do you need 2 approaches? If you look at the CT scan and you find a large anterior superior fragment in addition to the posterior column, this anterior superior needs to be stabilized because this forms an important component of the AP capture between the anterior superior and posterior inferior parts of the acetabulum. So this is where you will go through the iliofemoral approach, stabilize this using a buttress plate, then go back and stabilize the column using a posterior column plate, and then use a hemispherical socket with inferior fixation into the pubic ramus, as you can see here, to achieve stability in these sort of situations. Another example of the same with a anterior superior fragment, which is a key identification for 2 approaches, where we were able to put in a anterior buttress plate, posterior column plate, and the highly porous hemispherical socket. Of course, you can have some sort of fractures with a fracture neck femur with a complex ACPHT in an elderly man, and this was again managed with the double column plating and the hemispherical socket with inferior fixation. Rarely you can have combined pelviacetabular injuries which have been neglected. We see this in India, and this calls for stage reconstruction. So this was a patient, 55-year-old man, with a symphyseal injury, sacroiliac disruption, and an acetabular transverse fracture. So we did this in stages. We reconstructed the acetabulum as well as the pelvis, and at a later date, when the head resolved about a year later, but with more solidity of the fracture, we went in and did a reconstructive surgery, and this particular patient has done well at 8 years follow-up. Finally, in very complicated situations, you may have to use a cage with a cemented cup, and this cage acts like a 3-dimensional buttress to take care of the fracture and allows the patient to weight bear. To summarize, medial defects with intact column, you can use a rim fitting cup. Discontinuity of columns requires fixation because the acetabulum functions as a keystone. Highly porous hemispherical cups with option for inferior fixation has become the cornerstone of managing these injuries in my practice. Cage with cemented cup is a bailout option, but as I told you, hybrid fixation is a foolproof way of socket reconstruction using a dual mobility in order to avoid instability in these complicated situations. Thank you very much for the opportunity.
Yeah. So, Krishna sir, if you can spare another 10 minutes after the Dr. NEMADE session, we can take some question. Otherwise, we will have to take few questions right now.
No, I will wait. No problem.
Okay, thank you. Great. So, Dr. NEMADE, you can go with your talk. Yeah, this is very important, and basically it is based on the impaction, the location, the geometry, and the prognostic factors. So, go ahead, Dr. NEMADE.
Yeah, thank you so much, Kishore. So that's the place where I work, KM Hospital. So now we know that the elderly population in India is increasing, and there's going to be a lot of increase in the geriatric acetabular fracture in years to come, and we are going to face exodus of these patients in the future. And we know that it is because of the improved life expectancy as well as the population curve that all this thing is happening. Why do we need to discuss geriatric acetabular fracture as a separate entity? Because these patients have medical comorbidities. They have different fracture patterns than the younger one. They have osteoporotic as a complicating factor as far as the presentation and the fixation is considered. Implant purchase in a poor bone stock. And again, need of early mobilization, as KRISHNA pointed out, is the key aspect in this management. So we need to discuss what are the demographic and epidemiological data, the mortality rate, fracture configuration, the ways to manage and fixation strategies. Most of this have already been discussed, so I just jump down directly to the management options. So we have all these management options which have already been discussed. And the key aspect in this is the impaction injuries. And that has been discussed time and again in this webinar, that impaction injury leads to the problem in the management. So what are the common fracture configurations that we are looking at? We are looking at the anterior column with posterior transfer. That is the most common type of this thing. Other fracture are the anterior column with quadrilateral plate, and some peculiar fracture patterns such as the posterior column fracture, the dome impaction. And the dome impaction need not be just one kind of a thing. There can be double impaction. I'll show you some cases of triple impaction as well. And a certain rare patient do have high energy trauma. They lead to the posterior family of fractures, and they generally have poor outcome, and THR is kind of indicated in those kind of the injuries. So anti-injuries, we know this Angelin article 2003 show that gull wing sign is 100% predictor of failure. So it is the key influencer in management of the low energy acetabular fractures. So what is an impaction injury? It is basically a fracture into the subchondral bone. So look at this fracture, which was fixed. Okay, looks good, but 2 months it displays. Another fracture, fixed well. Again, later on displays, fracture. So all these fractures fail because of the gull wing sign. And Angelin said that this patient have inadequate reduction, early fixation failure, joint narrowing and subluxation to the level of 100%. And that made for a case for total hip replacement is this kind of patient, but that was 2003. Let's see what has happened. Angelin very categorically pointed two reasons why this happened. It is because this superomedial area is difficult to access with the conventional approaches, and it is difficult or impossible to get any kind of bone graft or hardware. So we had a problem statement made very clear to us that we have something to manage something that is difficult to access and difficult to support. But the solution was simple: improve the access and improve the support. So understanding is very important, and that's why to access that area, we need to recognize first it preoperatively, we map it, then we need to assess it and visualize it directly and indirectly. So we see the mechanism of injury of this injury. These are either anterior column or the ACPST or some kind of transverse fracture. Most of them are the anteromedial vector injuries. So we see this when this fracture occurs. So in elderly people, when the head hits the acetabulum, the subchondral bone is weak. It does not transfer the load to the inner cortex, and it fails first. And then it tilts, and then the head goes migrate in. So these are typically low energy fracture occur in elderly. Outside cortical, by outside means I mean the inner cortical injury is less, and these are typically the ACPST or the anterior column with quadrilateral plate, so-called the police door opening deformity like that. So look at this fracture. The cortical injury looks pretty innocuous, but look at the grotesque articular injury. The another type of fracture is little high energy trauma, where the head first fractures the lower half of the acetabulum, but head still migrates in, and while it's going in, on the way it chips small amount of the acetabular fracture, causing that small kind of the impaction fracture. This generally looks in high energy, more younger patients, and the outside cortical injuries and displacement much more, and typically occurs in T or transverse type of fracture. Look at this fracture, very grotesque type of injury, but we see that small impaction fragment which has a hinge much more medial as compared to the lateral hinge in the previous fracture pattern what we have seen. Now when we see pathanatomy of these fragments are generally located underneath the confluence of the fracture lines. So if you see the fracture lines, they generally confluence at one point, and underneath that will be the location of the this thing of the impacted fragment. And we have different kind of approaches, but the AIP approach is the approach nowadays and Parector's approach to deal with this kind of injury. How to reduce it? There are two methods. Either we can fix the column first and then make a window and punch that fragment down, or we can directly tackle that fragment before fixing and then kind of reduce it and put some kind of support, either bone or metal underneath it, and then fix it like that. So such impacted fragment can be reduced and then can be fixed. So to recapitulate, first is lateralization. So we lateralize and then we do either central to periphery reduction or periphery to center reduction. So that was the periphery, center to periphery. First we reduce the impaction. Here we first reduce the column and then reduce the impaction. What are the fixation method? Fixation method, two key aspects. Number one, the subchondral support. So whenever there is a subchondral impaction, we need to support that impacted area with some kind of structural bone graft. Previously, we used to use cancellous bone graft that used to fail. So we know that it should be some kind of a structural material. So structural bone graft, either in terms of a cortico-cancellous block, or we can use cement, and a peripheral buttress in terms of various plates. So we can use either spring plates or a kind of a specially designed quadrilateral buttress plate. So we have different options of the subchondral graft, such like this. So here we can put buttress screw like that, or we can put cements for the subchondral support. And peripheral buttress can be like this, one supra, one infra plate, or we can have spring plate, or we can have the quadrilateral buttress plate. Now look at the impaction injuries. Now impaction injury, as per the location, there are 5 types which we are trying to find. So one is the anteromedian, which is below the concavity of the ilium. One is posterior or posterior superior. The second is double. That means it can be anteromedial as well as posterior superior. Sometimes it can be triple in terms there can be inferior impaction as well. A very peculiar type of a posterior inferior impaction can also be seen. And very rarely we see pure superior impaction, as Dr. Michael has presented in his talk. So this is a typical AMDI, anteromedial dome impaction, where the impacted area is here, anteriorly and medially, somewhere over here, like that. Another is the posterior superior, where we see that a fracture line here and a quadrilateral plate fracture. But look at what is happening. Something fishy occurring posterior to the acetabulum. And look at the head reduction CT. The impaction area is posterior superior. It's not anteromedially here. It is posterior superior. And sometimes we cannot double or triple impaction. Look at this fracture now. Pretty nauseous looking fracture on the CT scan. Hardly any displaced fracture line. But we see that there is some anterior wall over fracture over here, lip fracture over here. And this looks normal. Whenever we have something happening like this, that means something fishy is happening underneath this bone, because we have fracture on one side, fracture on the other side. Intervening bone is intact. That means the fracture is inside that bone. And once we see a 3D reconstructed image with a head subtraction, we can see that the head has opened like a flower petal, and we have seen a triple impaction. We have anterior part that is impacted as well, the anteromedial as well as the posterior superior kind of impaction, and this is kind of a triple impaction injuries we can see. And then sometimes we can see this posterior inferior internal impaction, exactly opposite of this fracture, where we see a burst fracture of the quadrilateral plate on one side and a burst fracture of the posterior wall on the other side. And intervening vertical limb of the sciatic notch is hardly any displaced. That means something fishy is happening underneath this bone, and that is typically the posterior inferior impaction, which is very well noted by Letourneur even back then. Look at this fracture again. We can see a burst fracture of the quadrilateral plate, a burst fracture of the posterior wall. Vertical limb is undisplaced. That means something blowing out is happening there, and we see this posterior inferior internal impaction. Now this is opposite of the external impaction that we see in a posterior dislocation, where the head try to go posteriorly. Here the head try to go in, and the direction of impaction is reverse than the typical posterior wall impaction that we see. So how we manage? We look at this fracture, AMDI, one case example, where we see this fracture. We do AIP approach, tackle down this fragment to the confluence of the fracture side, put that fragment down, punch it down, put bone graft, close the lead, support it with a K-wire, and then fix it with the plates, and then we pass a subchondral screw as well to support that area, and that is how it looks after post-operatively. And then we do CT scan also, and we see that it is nicely reduced, and there is a very good bone underneath that and good support. And that manifests in the results that the patient heals nicely, So this is the at follow-up, and this patient is a farmer gone back to his day-to-day job. As opposite, look at this 83-year-old fracture. Almost imperceptible fracture of the dome here, almost similar to the case Dr. MEHOOL Acharya showed, where the head is medialized here, but we do not see any kind of the fracture here. But if you see the concavity of the dome, it is more or less straightened here as compared to the concave aspect on the right side. And combined with this, this suggests that there is an impaction here. Look at the fracture line, pretty innocuous looking fracture line. And that's how we need to locate it, map it, and the same way lateralize, reduce the impaction, this thing, suprainferior plate, subchondral support, and again it manifested in a good result. Lateralize the hip, and the patient goes back to his to her whatever pre-trauma activity. Now coming to the posterior superior dome impaction. Now this is a 67-year-old female male. Though he was 67, he was highly active patient, and this is the injury where we located that it is posterior injury. Now look at how to image it during the surgery. Now if we see obturator outlet view, that images the anteromedial area, whereas if you image the obturator inlet view, that image the posterior superior area. So here we keep the patient in the obturator inlet view. So this is obturator outlet, and this is the obturator inlet. So we keep the patient obturator inlet. Look at the difference here. This is AP, and this is the obturator inlet, and here clearly we can see the impaction, and all our reduction and everything happens in that. So we put a plate temporarily on the anterior column, but the impaction remain there. So we go through the quadrilateral plate there, reduce that fragment, put a structural triangular wedges graft over there, reduce it and fix it. And that's the postoperative X-ray. And then we do the CT scan, and we can see that the posterior inferior area now is well reduced, and there is some bone graft underneath that, and it is very well supported. And that manifests again in the results, and the patient goes back, and the hip can be salvaged in this particular type of the injuries. Now double impaction. Look at this patient, 73-year-old Parkinsonism, simple fall. We have a fracture like this, and we see a CT scan, head reduction, and we can see that this impaction here anteromedially as well as small amount of posterior superiorly, and a Mercedes-Benz kind of a fracture in the quadrilateral plate. And look at the fracture, impaction posterior here, impaction superior here. And then again, we put the patient in OO view to reduce the anterosuperior impaction, and we put it in OI view to reduce the posterior superior impaction, and both the impaction are reduced, and that's how the postoperative X-ray looks. And that is at the healing. Now sometimes we have triple impaction. Now look at this fraction. It goes in, look at this, and anterior column almost look intact. This small undisplaced fracture, and inside it's almost like the hemisphere became like a cylinder, because the head is just ravaging, making its way, creating a cylindrical path in the acetabulum. And if you see from inside, we see a typical Mercedes-Benz fracture, thanks to Dr. MEHOOL Acharya for giving us that term, and typical Mercedes-Benz type of fracture in the quadrilateral plate in that area. And look at the CT again, we see there are, I'll go to the head reduction, this thing images. So look at this, there are triple impaction, posterior superior, posterior superior, and anteromedial. And all this again need to be reduced. So this is the complete burst opening of the acetabulum. And then we need to again do the same, reduce all this thing. And then, so this patient, they do not have good results. So look at this, there is some migration at the end of 3 months. Now posterior inferior impaction, by far the poorest of all. So we have a fracture here, generally a quadrilateral plate fracture, and the impaction that is occurring here. So this is the typical fracture. So we go in, so this is the fracture, we go in first and reduce the quadrilateral plate by anterior approach first. So as to create the base. So this is the anterior approach, STOPA approach. We fix it by the quadrilateral plate. This is a quadrilateral plate fixation by 2 plates. And then we turn the patient posteriorly and make a small osteotomy into the posterior area. And we kind of locate that area there of the impaction, reduce it, and fix it with the posterior this thing, and that is the postoperative X-ray. Now, very rarely we see a pure superior impaction, almost similar to the case which has been shown. These are pure superior impaction, and this patient presented early, and we kind of reduced it through the iliofemoral approach and kind of put a almost same principles: subchondral elevation, graft, peripheral buttress, but does just that the plates are superior like this. Another patient which comes to us late. Now this is almost at 2 months. Hip is already subluxated up. So still we tried to do it, and we were successful in getting the reduction and fixing it like that. However, it did not stay. It went up again, and the patient ultimately landed in a THR. So as far as outcome is considered, now we see 2003 article that 100% patient were failing. Now look at the new article, that is 2023. On comparing, if we have a good reduction group, then the outcomes are favorable. So well-reduced dome impaction could achieve satisfactory outcome in elderly. So still it is not 100% success, but we are still marching towards that direction. As far as mortality in geriatric acetabular fracture is considered, just to summarize the literature, mortality depends on not on what kind of treatment you choose, whether you treat non-operative, operative, fixation, or this thing. It depends on the age and comorbidities, and good medical management and geriatric support is most important. So to summarize, we have 5 different types of impaction injuries which need to be reduced. There are 2 types as per mechanism, 5 types as per location. SOPA approach gives very good access. We need to have followed 2 basic principles: subchondral support and peripheral buttress, and good results can be obtained, and many joint can be salvaged in elderly if proper principle followed. I'll share one just simple case to end this. It was a 73-year-old elderly epileptic patient. Similar, almost mirror image.
Pradeep sir.
Last,
you can just finish.
Yeah, so this patient was fixed, and look at this. At 6 months follow-up, it showed very good result and fantastic result on both sides. However, at 1 year, one of the hip collapsed. That because the avian of the impacted fragment. So that is another entity. Even though we have good result at 6 months, we may still have poor result. One hip survived, other hip didn't. Yeah. And that is the 3 months. Thank you so much.
Yeah. So my question to Dr. Krishna Kiran sir. Sir, are you there? Hello. Hello. Krishna sir, are you there? Am I audible?
Yes, you're audible.
Yeah. So my question is to Krishna sir, that in the deficit of TAL, because most of the time it is injured and deranged, the transverse in the case of transverse fracture also, whole of the inferior acetabulum is rotated. How do you take care of the anteversion and this offset?
Peter, I think you can open it up to all the faculty so that they are able to answer.
Yes, this is an open discussion for all the faculties actually, because
Could you repeat the question one more time?
In case of this acute fracture, when there is a transfer fracture, whole of the inferior part of the acetabulum along with the TAL is rotated posteriorly or posteromedially. So how do you take care of your this anteversion and offset? What is your landmark in that case?
Up till now, I've never seen a transverse fracture in an elderly person. For me, it's really a high energetic fraction in the young people. So I've seen a lot of, and also in transverse fractures, usually you can restore them quite well, in my opinion. And there's not often dome impaction or need to do an acute total hip replacement. It's mainly in the anterior column fractures. But again, I've never, up till now, not seen a lot of transverse fractures in the elderly.
So Mehul sir, anything you let,
Yeah, so I will just add to that. So I've seen some transverse fractures, periprosthetic acetabular fractures, which are transverse early and late, and I've dealt with them as well. And for me, I try and stabilize the columns. So I will try and so because you've got the hip out already, you'll be able to see the view like you would do with a surgical hip dislocation. So I would try and fire an anterior column screw, posterior column plate, and try and reconstruct those columns, reconstruct your anatomy, and then guide. Most of the time, the transverse acetabular ligament is still there. You're right. The orientation might not be perfect, but most of the time, the transverse acetabular ligament is still there. So I would recreate the columns to create the anatomy.
So if it is a delayed one, also you will put some effort to reduce it and then to do a THR.
No, if it's delayed, and it's you know 4, 6, 8 weeks, then I think then you're going to have to start doing osteotomies, etc., or extensile approaches, and the chances of getting an anatomical reduction are reduced, markedly reduced. So in that case, I would fix in situ, and then I would then use revision hip techniques to try and fill the defects and recreate the hip center.
Yeah, my question is again to Michael, that what do you feel that these recent advances in this anti-protrusive case and this jumbo cup and vis-a-vis with the anterior plating and doing a THR, which are biomechanically more stable and longer survival rate? What is your opinion in that case?
My opinion that it really depends on the age of the patient, and so if the patient has a life expectancy of more than 10 years and also requires to be more functional, I would try always to restore the anatomy as much as possible in order to place a simple rough cup. When the patient is older, I think you have to still provide stability, but it's not made to last for 10 or 20 years. It's a bit the same like a bipolar hip arthroplasty or a total hip arthroplasty. So, and I do think, for example, I have colleagues in Innsbruck in Austria, and they use a special kind of cage that has angular stable screws in the cage, and they have converted to only using this implant now because it allows them to just do the surgery through one posterior approach and really reduce the operating time. The follow-up they have with the implant, I think, is now 5 to 7 years, so not super long. But up till now, they have not seen any problems with the implant. The problem, however, is that it is very expensive, that the cost of the implant per implant in euros is about 2,700 euros for just the
We have a talk on that.
cage.
We have a talk on that.
Dr. Kishore.
Yeah.
Dr. Kishore, one question to all the panelists. Dr. Akash from Mysore.
Yeah.
If given a choice, if the patient is fit and presents on day 1 of trauma, so when do you plan the patient for an acute THR? Is there any timeline you want to establish if the provided the patient is medically fit with respect to all other comorbidities?
For me personally, as soon as possible.
Okay.
Yeah, similarly, as soon as possible. And I would try and do it all in one sitting. So do the fix and the replace all in one sitting if I can. If for any reason they are not, their medical status changes during the operation, then I may just do a fix and then come back a few days later or a week later when they're okay to do the replacement part. But 95% of my cases are done through in a single approach, as in a single sitting, not a single approach, single sitting.
Okay.
Thank you, sir.
So my next question is to Professor Romain. Most of the time we have seen that ACPST impaction, particularly the anteromedial impaction, even if they are very well reduced, we have seen there are loss of reduction in the post-operative period and leading to THR. So how do you think that what is the main cause of this failure and how it is different from the post-medial dome impaction?
I think that the bone quality in the older patients is not comparable with the bone quality in younger patients that suffer a high energy trauma. In this case, you have marginal impaction, especially in the posterior wall and posterior column. But in the older cases, you have the marginal impaction in the anterosuperior part. And it is very important, as has been said several times, that you restore the medial buttress. So the quadrilateral plate with these special plates. And then after that you try to restore the marginal impaction. It remains a big question to me, what is the best support to give to this below this marginal impaction? Is this cancellous bone graft? Is this a part of cortico-cancellous bone or something else? I think there are no prospective studies or observational studies that can solve this question.
Yeah, because many times we see that even if it is well reduced, there is loss of reduction, and in the very next few days it goes to THR. So which type of graft you advocate? Means this synthetic graft or autologous graft? Which type of graft is actually better?
If you have a good quality bone graft from the patient itself, you can try, you can give that. Also, allograft is very good. As I said, a third option would be a bone support from any company, but it is not known what is the best option. In every case, it should be stable enough to allow the patient to weight bear.
Yes, because the autologous graft in geriatric population is very less.
Very limited
poor in
in
quality also.
volume and quality.
Yes,
I agree.
Yeah. So, any more question, Tirtha sir, or else we can?
I have a question. Oh,
okay. Okay.
So, I have a question to all those experts who are actually in favor of acute THR. So these anterior columns which are really weak and osteoporotic, and what about the putting the homens through that fractured bone to have a good view on the of the acetabulum? So does that make a little bit challenging to put the homens on the anterior column, or do we need any other special instrument to have a nice view of the entire acetabulum?
Yeah, okay, so I will start that. So I think it depends on where your fractures are. I think, yes, you may need to bring your homen slightly more proximal or slightly more distal to try and visualize the acetabulum. But most of the times, if you insert that homen gently, you can get a good view. Sometimes, you may have to do extra releases if you need to. So you may need to release or partially release the reflected head of rectus to get, if it's a big patient, and if you want to move that femur anteriorly in a posterior approach. But most of the time, I think as long as you position it more proximally or distally, you can get that visualization.
Yeah.
May I ask a question to the speakers? We have seen a number of excellent cases with different solutions, plates, cups, cages, and also cones. How do you prepare your patient, and when do you take decisions what to use? Especially, I don't think that all these instruments and implants are available in the hospital for every surgeon. So how do you decide? And if you have special requests, would you wait a week, 10 days before you get these implants and instruments to go on, or how do you decide then? It's a very practical question, but I think it's relevant.
Yes, the question probably Dr. MEHOOL and Dr. HERTELEER will answer if KRISHNA KIRAN has left.
Definitely. I'm again happy to start that conversation. But so in our hospital, we have a multi-hole cup. So a trabecular metal type, hemispherical, multi-hole cup on the shelf. We also have the augments on the shelf, so that is on the shelf. But if I want to do something else, so if I want to put a cone prosthesis in, or if I want to do a PRS cup, which implant casts do, so more of the tumor type of prosthesis with a big 8mm screw, then you're right, then I have to order that kit in. But usually I can have it within 3 days. So if I order it today, I can get the implants by tomorrow, sterilize tomorrow, and I can use them on the 3rd day.
Yeah.
Yep. For me, it's a bit similar. All the implants that I use, we have them just off the shelf in house. I don't use. I do not have any experience with ice cream cone cups. I know my tumor colleague. He does, but I don't know what the waiting time is to have them delivered. But I don't expect it to be over 3 days.
Yeah.
Because a lot of these implants for the revision surgeries, if you have colleagues who do revision surgery, they are quite standard, and they in our center they do a lot of hip revision surgery as well, so it is available.
Yeah.
Daniel?
Yeah. So I think we should move into the next 2 talks. There are 2 talks and 2-3 cases after that. And then if we have time, then we can discuss. The next talk is Dr. Sujit Tripathi. He will be speaking on Dr. SAINI classification and its utility in acute management. Next to Dr. Sujit Tripathi. Yeah. Hello. Hello. Dr. Sujit.
Maybe a question in the meantime while we're waiting to mess. Percentually, how many times would you use a cone cup, and how many times would you use classic revision implants?
Yeah, so most of the time, if I'm dealing with a patient who is anywhere between 65 and about 80, physiologically fit, then I want to try and reconstruct the columns, put a hemispherical multi-hole cup and lots of screws with plates as well. So that's what I'll do. But in the older patient, so 80s, 85s plus, 85 plus, with those patients, I want to try and they've got a fracture involving both columns with significant displacement, then I want to try and use one approach, single approach, a quick-ish approach, so within a couple of hours if I can, and that's when I'd use something like the cone or the PRS. So that would be my indication, to try and do a relatively quick operation, one approach. And with those patients, my strategy and my thinking is that they're 85, they're 87. Hopefully, this cone prosthesis is gonna outlive their survival. Yeah.
Yeah. So, Dr. MEENA, are you ready? Hello, Dr. MEENA. Yeah. MEENA, sir.
Okay. So in the meanwhile, can I ask?
Kishore, can you move on to Praveen, who is here at least, so that we can stick to
Yes,
time,
yes.
and we are short of time, and it
Yes,
will
sir.
be difficult
So,
later.
Dr. Praveen, are you ready with your case? Dr. Praveen?
Yes, I am very much available. So let me just share the screen, and I think there is a problem. Can you just play my presentation, please?
I think, is there any problem with me, or?
If you can play the presentation, please. Thank you.
Okay.
There are some technical glitches right now. Kishore, can we have this presentation, or do we? Till the meanwhile, I would like to ask from the faculty, we know when we are sure and certain that we are going to be doing a replacement, what sort of replacement we are. But I would really like to know in your practice, how the experienced acetabular surgeons in a 70-year-old patient decide that they are going to be doing an open reduction in dermal fixation or doing an arthroplasty along with fixation. Two are totally diametrically opposite chart territories for an acetabular surgeon. How do you decide, and which are the factors which you are looking for in a pre-operative scenario or in the intraop scenario, by which you decide this is the patient I'm going to do a fixation and this is what requires a replacement? Do you get some specific investigations beforehand, or it is just your gut feeling based on or the marker? Impaction, you said recently there is a lot of controversy regarding impaction, which is impaction and which is displacement. It's difficult to quantify. So how do you tell?
If I can start, first of all, I always discuss it with the patient beforehand. If they are fit and over 70, I explain to them that I would like to have it solved with one surgery, and I ask if they have a certain preference, what are the pros and cons, and then I would mainly tell them that if during the surgery I am unhappy about the reduction, or still have the feeling that there is a marginal impaction or something that I have not reduced. And nowadays, more and more, we use intraoperative CT to really assess and check it and also measure it. And if then I believe this is likely for an inferior outcome, then I will convert to it. If they are over 80 and I know that it's going to be challenging to reduce it and it might take a lot of time, and that in the end I will still not be happy with the result, I will immediately suggest to them the fix and replace solution, but I will also tell them what the risks are. So mainly the most difficult is for me the patients between 60, 65 and 75, because those are usually really fit.
Yeah. I think Dr. MEENA is ready, and we can go ahead with this mainly the Indian perspective, how the financial challenges and this economic condition influences outcomes and management. Okay. Dr. MEENA, please carry on. Dr. MEENA. Dr. MEENA. Please carry on. It is audible. Okay. Dr. MEENA. Okay. So it cancel करे कि stop sharing कैसे करियो? नहीं इनको stop कैसे करना पड़ेगा? इनका वीडियो ऑफ कीजिए. So, Dr. Sunit, are you ready with your case?
Yeah.
Oh, you can go ahead.
No, but you have to unshare the screen first, then only I can share.
Stop sharing. Okay. Now we can start sharing.
Yeah. So can you see this?
Yes, yes.
Yeah, so mine is actually not a big case. It's a simple case. So it's a 77-year-old with history of inguinal hernia, operated 15 years back, and with osteoporotic and anterior superior dome impaction. And as you can see in the CT scan, it's mainly the anterior superior part which is mostly displaced, and the medial column was comminuted, and the anterior superior dome was impacted. Superior and anterior part of the dome was impacted. So I usually do not do the acute THR in those sort of situation, and this was also complicated by the inguinal hernia operation as well. I was thinking whether to go for the the STOPA approach or not. Then I thought probably it was done 15 years back, so I went ahead and did. And this is the impaction of those anterior superior part, as you can see here, and then this is what I could get done through the STOPA, and at least the hip was looking reduced. I said about 7 months down the line, and now that patient is doing well. But I don't know whether this will last long. But I think once it has at least now consolidated, and whether so this is about my case. I don't know how to answer this. Yeah, so this is my case, I think, and I don't know whether that was good enough decision or not. So I want to have an opinion of the panelist.
I think these fractures of the anterior wall above the acetabulum are very difficult to fix. I tried to put them with a second buttress plate in front because you cannot screw them right, but I think it's a challenge, and the outcome is very good. When we have very anterior dome impactions, I don't know if they're important. I usually leave them because anteriorly there is no weight bearing.
Yeah. So also, I mean, I have seen that not all those dome impaction behave similar. The majority of them fail, but few of them actually can cope up well. And even if with the incongruent hip, they usually have a painless hip for quite a long time in this geriatric case as well. So. So, I mean, is this a straightforward case for the THR in this sort of situation in your hand?
As I remember, as Professor Romas always told me, an acetabulum fracture is never straightforward. It is always a challenge, and there are always pitfalls. So I still think of that quote regularly, especially in cases like this. So it's you can only the only thing you can do is prepare yourself, think of all the different options of how you might do it, and hope that it works. And in the end, think, did I think of everything? Did I try everything? And I think your result is good, is acceptable for sure. But it is never straightforward, especially in these cases.
Okay.
So can we move to the next case? Dr. Gaurav, are you ready with your case?
Yes, I'm ready.
Yes, please share.
Is my screen visible?
Yes.
Yeah, so I'm going to present a geriatric acetabulum fracture case. So a brief history. The patient is a 76-year-old male, is diabetic for the past 20 years, Parkinson's for the past 10 years, multiple laparotomies done in 2011. Patient also had a diabetic foot ulcer 6 months ago with sepsis, healed now, change in speech for the past 6 months. Now he has a history of fall at home. It was a low velocity trauma. So this is the way the patient presented to us in the OPD. Now, I just want to ask the panelists, it's a left-sided injury. So the first question asked by the relatives was, can it be managed conservatively? So I just want to ask the panelists that is this fracture can be managed conservatively based upon just this X-ray?
Yeah. Vivek sir.
In my opinion, in my experience, I would always suggest to these patients to do a minimally invasive percutaneous fixation because the operative risks are minimal, and then I allow them to weight bear immediately. 95% of the time it goes well, but sometimes it still displaces.
Right. So based upon the comorbidities, when you see that there was no great dome impaction, there was no femoral head impaction, there were not much negative predictors for the fracture, and depending on the comorbidities, we decided to manage this case conservatively. And after 3 months, patient again presented to us with shortening and with this collapse. So we thought that where we went wrong. So the CT was done. You can see the head collapse as well as the acetabulum collapse. And the shortening, about 2.5 to 3 centimeter of shortening was there. So minimal displaced fracture with no negative predictors went from a decent looking preoperative X-ray to a completely collapsed fracture. So we went and see the literature. So these were all the publications which were there, and as already discussed, it's the anterior injury which is most common in elderly patient. And in this article, we found that if there is an intact acetabular articular fracture with fracture displacement less than 2 mm in elderly patients and femoral head congruence with the intact acetabulum dome out of traction could be managed conservatively. And our patient was fitting in all these categories. And also, if we see the Charlson comorbidity index, which was almost 6 in this patient had a diabetes with chronic complication, and patient had neurological disorder like Parkinson's. And this was the ideal candidate where the patient could have been managed conservatively, but still we failed. Now, if we see patients treated with traction alone, 79% is 1-year mortality and 50% mortality rate is within 90 days. 84% of the cases had non-operative treatment. So finally, impaction grafting was done and a multi-hole cup was used. Sizing was almost 5 to 6 mm. It was a 60 mm jumbo size cup. There was a little bit of higher hip center, but then we were able to fix this like this. And now this is the current situation where we started weight bearing of this patient. This was at COVID times where we couldn't get the CT preoperatively of that patient at the time of injury. So conclusion is to get serial X-rays in these patients and a CT scan and tailored treatment approach. And the Charlson comorbidity index is a good guide to see where we can manage these patients conservatively or we have to go for an operative intervention. Thank you.
Yeah, very nice presentation actually, because few things are taken up. So, Dr. Meena, are you ready, or we can because your Dr. Sujit is not going to present due to some technical reason. He is not able to share the screen. So, Dr. Meena, so are you ready, or we can go to Dr. Praveen case? So, Dr. Praveen, are you ready with your case?
You need to start the presentation for me, please.
Okay. Okay. So, is it visible there?
Yes.
Okay. So go ahead.
Yeah. So essentially, just a second, give me 1 minute. Yeah, let me go to the full screen. Yeah. So this is a 70-year-old lady who presented with a transtectal fracture following an RTA with a comminuted posterior wall, as you can see. If you can just play the video, please. Yeah, and then essentially, this is the dilemma which I wanted to share in these kind of tricky situations, because the confusion in an elderly person would be to decide whether to go ahead with a fixation or to go for a fixation and replacement. This case demonstrates, next slide please. Again, the coronals and the axials demonstrating that it was a transtectal type of acetabular fracture with the comminuted posterior wall. Yeah, we can go to the next one, please. So intraoperatively, we could see that the sciatic nerve was actually divided by the piriformis, the anatomical variation. We do come across these kind of variations, so we need to be very watchful, especially when you are dissecting close to the sciatic nerve. I just wanted to demonstrate that because that was visible in this particular case. Next slide, please. So this was the comminution there. As you can see, significant chondral damage. Next slide, please. I still managed to decide to go ahead with the fixation, and as you can see, the fixation started off with lost K-wire technique with the posterior column first, and then the posterior wall comminution, sorted out the jigsaw puzzle, and then restored the anatomy well. You can see the post-operative radiographs on the next slide, please. As you can see, that's the AP pelvis demonstrating a congruent hip. Next one, please. The Jude views again demonstrating. Now, this patient had symptoms at 6 weeks follow-up when she was complaining of clicking and pain. We got the radiographs done. Unfortunately, I could not get the 6 weeks radiograph, but then at 3 months, as you can see, the head completely resolved. And if you go back and look at this particular case, what went wrong, although the anatomical restoration was achieved, is the key question. We can open the case for discussion with the panelists, or if you want me to show another case and then we can discuss both of them together quickly.
Yeah, we can discuss both the case at the end.
So just to highlight what are the potential factors in these elderly patients, as it has already been embarked on, that osteoporosis is a key thing, and especially if somebody is an alcoholic and a smoker, you need to be even more careful. And the fracture pattern itself, if there is gross comminution, head indentation, chondral damage, and if there is previous dislocation, all these factors add up to the loss of blood supply or cartilage damage. And the surgeon factors, how much ever precautions you take, still sometimes the blood supply could be affected, and adequacy of fixation again is equally important in the elderly patient. So next slide, please. This went on for a total hip replacement. Again, next one, at follow-up, she was doing very well. Let's move on to the next case quickly. So this is a 64-year-old car versus divider and high velocity injury. And you can see this is a comminuted posterior wall again. Next slide, please. This was close reduction was done, and then the CT again demonstrated. Play the video, please. Yeah. As you can see, yeah, next one. It's not a video, just keep going. Yeah. Yeah, so you can see that the significant comminution was there. The previous slide, just one slide back, please. Yeah, again, comminuted wall, and there was some amount of column involvement, but not too much, no displacement. Yeah, move on to the next slide, please. So intraoperative pictures, again, lost K-wire technique, good restoration, except for some head indentation, which was again visible in both the cases. There was no other harbinger of failure. Yeah, just have a look. Next one, please. So that's the post-operative radiograph demonstrating adequacy of fixation and a congruent joint. However, this patient came back at 6 weeks. He was fine at 3 months again. Next slide, please. And these are the Jude views, again demonstrating good reduction and stabilization. Can we go on to the next slide, please? Again, at 6 weeks, this was the image, and move on to the next one. Yeah, 3 months post-op, all the inflammatory markers, everything was fine. You can start suddenly seeing that the head is becoming like a cone. It lost its sphericity, and the head indentation part is again engaging. So patient had significant pain. However, there was no clinical or radiological evidence of infection. So next slide, please. And this was what was found intraoperatively, and a total hip had to be done for his significant symptoms, pain, difficulty in weight bearing, and not able to move. So I just wanted to open this cases for discussion. If when do we decide primarily should we go ahead with total hip replacement or try to restore it, was the key question. One is a 72-year-old, one is a 64-year-old. I just wanted to bring these cases. Even with decent reduction and fixation, sometimes you do have failures, and that is the crux of the problem of dealing with these elderly patients. Any questions, Tej?
So to the panel, so we can stop here and we will start discussing, or
yeah, you could. I think we could stop here and then we can discuss. Yeah.
So there are few points to be concluded here. One is BMD, bone mineral density. Other one is BMI, and other one is the diabetes. So coming to the BMD, is there any cutoff level that beyond which we should think of acute THR rather than doing a osteosynthesis? My question is to all the panels and all the speakers.
We usually don't have any information about BMD, so low energy fracture in the acetabulum or in the pelvis are osteoporotic, so we don't wait for BMD.
Okay.
BMI usually protects from osteoporosis, so people with a high BMI usually have a better bone quality.
Yeah.
I think the cases you showed, the first one, transverse and posterior wall, has the worst prognosis in every series. So you had a marginal impaction plus multifragmentary posterior wall plus transverse. For me in this age group, this is a reconstruction with a posterior plate and then THR.
Absolutely, I agree with you, Dr. Wagner. Yeah.
So BMI, any cutoff level on BMI that will warrant or that will predispose to failure of the fixation like this?
I don't know if they fail more than the other ones. They have a higher risk of infection, and the approach is a bit more demanding. But the failure will not be. I don't think it will be different. If you talk about the posterior wall, when I started, or there is a tendency to have them not flex the hip and so on. But already when you're in the bed and you lift up your leg, you push the hip inside the posterior wall with 1 to 2 to twice the body weight. Yeah, I don't. But for me, BMI is not different.
So my question is to Roman sir. Sir, I have seen few cases that you have revised in acute THR and you have done the medial buttressing plating. So according to your views, what are the failures of acute THR? Means lack of medial buttressing or something like quadrilateral plate defect. So what is the main anatomical construct that we need to focus during the ABC fracture and ACPST fracture for acute THR?
What is important, I think, is that you reconstruct the cup, the area where the cup will be, as a stable construct. Both columns must be brought together and brought stable in a stable manner together. Otherwise, you will not be able to fix your cup in a stable way in the acetabular bone, and especially not in elderly patients where the quality of the bone is even lower than in younger patients. So I think most of the cases that fail are cases where the cup has not been placed in a stable manner on the acetabular bone. So you have then a high risk of early loosening because you want to mobilize the patient, and that means a total weight bearing. And when they mobilize, then there is a higher pressure on this cage, and there is a high risk of loosening. And then you have to analyze where the most important part of your instability is. Is it in the anterior column? Is it in the posterior column? Do we need to fix both, or can we fix both with a special plate and with intraosseous long screws? And that is all a question of preoperative planning and looking at your CT scans, looking at your X-rays, and step by step taking decisions how to do it.
Yeah. So my next question is to Dr. Michael. That is there any study like that plating the anterior column versus the jumbo cup along with this pubic ramus screw through the cup? How these two constructs are comparable? Means these are equally good, or something is superior than this?
No. So it goes basically back to what Professor Romas was saying. And so you want to restore the both columns, and you assess where the displacement is, and reducing the displacement and keeping it. If it is just a simple kind of fracture, you can use a long anterior column screw or a long
No.
posterior.
I'm not telling that. I'm saying the cob holding one screw through the cob holes to the pubic ramus. That construct versus the antral plating. How do you compare? Look at these two different constructs.
I think that the stability should come from the plates and screws around the cup, and that the cup has to be these porous cup have to be placed in a press fit manner, and the screws mainly cause the rotation or stabilized against rotation, but they will not hold the fracture together. I believe that in the porous bone they are not strong enough. This is also one of the reasons why I now use more and more long anterior and posterior column screws to really stabilize the acetabulum more than plates, because they give much more stability.
Yeah. So now my question is to Dr. Gaurav. Sir, is there any cutoff level of HbA1c like in diabetic that you will not go for THR like thing in acute setting?
So in elective surgeries, we take a cutoff of 8, but in a traumatic situation, there is no cutoff value.
Okay.
In a traumatic situation, we have to go in and make them mobilize early.
So anything to us, because we have 10 minutes left. So
can I ask a question to all the panelists?
Yeah.
Normally, our head does not touch the quadrilateral plate at all during normal articulation. That is because the diameter created by the anterior column and the posterior column is narrower. It doesn't allow the head to go in. So for all THRs, the crux is the same narrow corridor has to be created rather than creating a wider corridor, because no part of the head articulates with the quadrilateral plate. You are just replacing the head with an artificial head. But we are forgetting that we are not recreating the circular anterior column and the posterior column. So I think the crux lies in recreating the correct anatomy of the anterior posterior column, giving it strength so that your THR remains stable.
So anything to add, Vivek sir?
I completely agree with these ideas. However, I had to learn that our revision arthroplasty surgeons, they rely on a posterior column and on a supraacetabular region to fix a Bohr-Schneider or a Kerbuhl ring, and then for them it's okay to cement in there a double mobility. They don't rely on the anterior column fixation. It was new for me, but it seems to work, and they have experience with pelvic discontinuity, and it works also there. So I'm a bit between these two ideas, but we usually rely only on posterior column integrity and posterior superior bone to fix screws and then to fix the cup. As Michiel told before, the cup from Innsbruck also relies on this bone region. And then you put in there the reinforcement ring and cement the cup.
I think it's important that you make the difference between a revision in a younger patient that had a primary total hip for arthrosis and a patient that is older and has poor bone stock. And this lower screws can give additional stability to the socket, additional to that what you reach or can obtain in the superior region above the acetabulum. So
Okay.
it's an additional security.
Yeah. So we'll conclude with one talk that Dr. MEENA is ready. He was just going through some technical glitches. So it will be fair enough that we will conclude that talk. So Dr. MEENA, please share your screen and we'll conclude that with that talk. Yeah.
Yeah, is it visible?
Yes, it is visible and audible.
Audible also?
Yes.
Yeah.
So 10 minutes, I think. So you can skip something.
Yeah, I
and
will go
repeat it.
fast.
Yeah.
I think most. So good evening to everyone. I think most of the things has been already covered. So I will discuss briefly all about the things about the fix and replace technique. So we all knows that the gold standard treatment for any kind of acetabular fracture, including in elderly, is ORIF. Like in this case, this was an 84-year-old male, which was treated by the ORIF through the AIP approach, and he's doing really well. So whenever
You do slide share mode.
Okay. So whenever possible, you should go for fixation in any kind of cases.
Umesh, switch over to the slide share.
It is not coming, Umesh. Your slides are not moving.
There is a big square in the corner of your...
1 minute.
No, not there, not yet.
Is it?
Go to the right corner and see below that there is a slide share option.
I think I have shared my screen.
No, you have shared your screen, but you have to go to the slide share mode.
Okay.
In the PPT.
Is it okay now?
Not okay. In the last part of the PPT, in the lower corner.
Yes.
Not now. Yes, now it is there. Okay, go ahead.
So whenever we are going for ORIF, the critical, the deciding factor that is affecting the outcome is the congruence of the joint, which should be within the 2 mm. So if it is in the congruent joint, there are less chances of osteoarthritis. But if the displacement is more than 2 mm, there are high chances of osteoarthritis in later stage. And there is subsequent conversion to the delayed THR is comparatively having poor outcome as compared to the primary THR in OA cases. So we all know that THR is the well accepted treatment for late sequelae cases, which are treated either conservatively or operatively. But in last 2 decades, there is a recent technique which has been developed particularly in elderly cases is a fix and replace technique. So what are the advantages? Let's coming to the advantage of this technique. There is faster recovery. We can allow early weight bearing. We can manage the concurrent hip disease, and we have seen the better functional outcome and fewer complications like thrombotic events, decubitus ulcer, and pulmonary complications also. So these are the certain indications which have been already discussed, like when the fracture is present in the pre-existing arthritic hip, when the salvage is not possible, and we are expecting poor outcome in spite of fixation, then we can go for directly fix and replace kind of surgery. So these are the certain decision-making factors like patient-related and fracture-related, like old age, obesity, lifestyle, and cognitive impairment. If these are there, we can go for directly fix and replace. And like fracture-related, when there is dome impaction, severe comminution of wall, when we are having inadequate articular surface reduction, even after ORIF, when their head is impacted, and other things. Like these are the few examples where we can go directly fix and replace technique. When there is a failed fixation, associated femur head or neck fracture, we are seeing neglected cases, dome impaction. So these are the certain few examples where we directly go for fix and replace technique. So these are the surgical challenges we face in the acute THA and acetabular fractures. There is a distorted anatomy. There are multiple fragments which are not possible to fix. There is defect is there, pelvic discontinuity is there, and the important thing that is comes in these cases is the osteoporosis. So that these are the certain keystone things that to be remembered while doing a successful fix and replace technique. A meticulous pre-operative planning is essential in form of proper radiograph and CT scan. We should exposure is important. We should expose as per the need of the fracture, and we should the thing we are discussing about the availability of all kind of instrument and possible implants as backup is the key point for success. So careful planning is essential. We can use any kind of anterior approach or posterior approach depending upon the fracture pattern. But whatever the approach you use, your primary aim should be achieve the stability of fixation for successful outcome. Like in this case, it was done by someone else where they tried to fix and replace, but due to unavailability of adequate implant and proper techniques, it fails on the day one. So while doing the fix and replace kind of treatment, these are the certain things which should be kept in mind, and we should have all kind of implants. We should carefully plan the case, and your planning should be tailor specific depending upon the patient and fracture characteristics. And one thing that is important, you can go for either prosthesis alone, we can go for prosthesis with any kind of cage or bone grafting, or we can go for any kind of fixation along with the help of plates, cable, or cage. And if the fracture is minimally displaced, we can go for any kind of percutaneous fixation, then can go for replacement. So the in these cases where we are going to fix and replace, anatomical reduction is not mandatory. You should need an adequate stable construct where we can which allows your cup placement. So the another important thing is that your implant should not comes in the way of your acetabular reamers and screw placement. That is the things we should be kept in mind also. So to achieve the stable construct, we should address the acetabular defect, which can be addressed with the help of either graft, which can be taken from the either autograft from the femoral head, or we can use allograft if available, and any kind of augment can be used if available. So that these things already discussed, that we needed a highly porous metal cup with multiple screw options, and dual mobility is always preferred in these kind of cases. So these are the certain pillars where we can put various kind of screws through the multi-hole cup. So these are the few challenges we faced while doing the acute THR. So it's an technically demanding and associated with a very high risk to the patient. And challenges includes the long anesthetic time, high blood transfusion rate, dislocation rate, and also technical difficulties. And the particular thing that we're facing in our Indian scenario is the financial constraint and the government policy foundations. So this is the last thing that is quite important in our scenario. where we are facing these things, that every patient is not financially potential to go for dual mobility or multi-hole cup. And if the patient having government policy, there are the certain limitations are there that we can't go for any kind of higher cost implants. Like these are the certain data I have collected, that there are limitations while doing the surgery, because the reimbursement we are getting from the government is quite low, in which we are not able to do in a good setup. So in schemes we are the few words about the government schemes which we are facing problem in our Indian scenario, that most of the patients are now coming in with these schemes, and rate of these schemes are quite low and unsustainable, particularly for the fix and replace technique, where we needed a multi-hole and dual mobility kind of curve. We can't go with these schemes. So definitely that is going to affect our outcome. And what we are seeing nowadays, that other insurance companies are also decreasing their reimbursement rate as per the these schemes are coming in market. So this is the important thing I want to highlight, that this need to be addressed at the national level. We should we can ask our government to discuss these things. So these are the certain example where we have go for fix and replace technique. So this was a case where the fracture dislocation was there, posterior wall was fractured, fixation was done with the only screws and replacement was done. This was another case of 85-year-old male where there was anterior medial dome impaction was there. So considering the age and multiple comorbidities, I have gone directly fixation through the AIP, and dual mobility kind of fixation was done. This was another case of posterior fracture dislocation, which was neglected for, I think, 3 weeks. So this was in more than 60 years of the age, and head damage was present in the CT. So I have gone directly through the KL approach, and fixation with the primary fixation and replacement was done. So this was the case which came. I have gone for revision. So I have been called for revision. The primary surgeon has done the fixation and replacement was tried. He has mixed the both cemented and uncemented cup. So he has used uncemented cup with cement inside, because it was migrating inside and the availability of implant was not completely there. So they called me on the next day. The another important thing, that there was a economical constraint was there. So we have applied a Indian cage and Indian cemented THR was done in the same case. So to conclude, so ORIF is a standard treatment, including in elderly patient, but we can go for acute THR in certain specific cases, like when there is a factors like patient-related factors, fracture pattern-related factors, and certain other factors that may affecting your outcome of ORIF, then you can go for acute replacement. Thank you.
Yeah. So you can stop sharing from there only. Yeah. So it is a very alarming situation and wake up call for the association how to deal these type of situations, because in a state like Odisha, the acute synthesis for the acute synthesis, the implant cost is 10,000 and the surgical cost is hardly 38,000. And for the acute THR, the implant cost is 55,000 and the THR cost, surgical cost is 1 lakh. So considering this type of complex situations, obviously economy and financial aspect is a key factor that means it is alternating or it is somehow influencing your decision of surgery, somehow it is biasing. So how we are going to tackle this situation in the next decade, this is one question. And the next question is there any standardized grading system, like scoring system, to come up in future for doing acute THR versus acute osteosynthesis? So these are the two things I want to discuss in depth. Then we will conclude in few minutes. Thank you.
The discussion is ongoing, but what is happening now on a scientific level in Europe is that we are setting up a multinational randomized control trial comparing FIX with fix and replace. The inclusion criteria are, we are not strict at all at the moment to decide on which indication, but the surgeon basically decides who is fit for inclusion in the study, where they would doubt, should I fix or should I fix and replace? And for the moment, 6 countries are participating already because the numbers are very low, and we hope by gathering all this data in a structured manner and also seeing fixation techniques from different surgeons, that we can give some more clear guidelines on what is done and what is not done. That's what's happening. But I think for the rest, I think all the speakers have been very complete, I think, on their ideas of when it can be done and can't be done.
Yeah, Dr. Wagner, final comments from you.
All said, it was a very nice meeting. Thank you.
Yeah. So, Dr. Romans, any final comment on this scoring system, like in future? Anything you want to add to Michael?
Yes, I agree with Michael that we need more experience and especially more data to go on with, let's say, an organigram for everybody to decide if you will go to the direction of a total hip arthroplasty or the direction of a osteosynthesis. We need more experience in that, or more data. But for now, I think it is up to the surgeon to decide which way to go. And we have heard today which are the factors that give you the tendency to replace, and which are the factors that may give you the decision to fix the columns, especially taking in mind the quality of the bone and the marginal impaction. We have seen that these are major factors to decide in favor of a total hip replacement. It is the decision of every surgeon in front of his or her patient to do this thorough analysis, to talk with the patient, and to find the best solution for every single patient apart.
Okay. So, Dr. Mehul, are you there?
Yes, doctor. Oh, yes, sir.
No, I think he's there.
Dr. Kishore?
Yeah.
Can I just one question to the panelists?
Yeah.
In case of acute setting total hip replacement with comminuted posterior wall, which is irreconstructible, so do you suggest directly going in for augments, or do you utilize the femoral head as and plate it and then go for a total hip replacement?
Yes, that was the question to Dr. Mehul. Actually, I wanted to ask whether he's there or he's in the meeting, but he's muted.
He's there. So let the other people answer that part.
Okay.
Maybe just can take the femoral head, you osteotomize, shape it, and reconstruct your posterior wall.
I agree.
And buttress it with the plate, of course.
Up till now, I've never used an augment for that indication.
Dr. Sunit, you have some experience with the femoral head? Dr. Praveen, Dr. Sunit? Okay.
We commonly use that in India as well because of constraints of analysis, but we feel that the femoral head is the viable in you're waiting a good bone stock along with that. So I think it's a commonly used thing everywhere all around the world for this.
Yes,
only
can I add to that? Yes, Dr. Yeah, we use femoral head quite a lot. Yeah.
So,
Sujit, Kishore, can I add something to that?
Yes,
if you don't mind. Kishore, what we have been doing for some of our cases, especially when we're using the femoral head, is to use the femoral head and carve out using a reamer of one size lesser than the femoral, the acetabular cup size. So suppose the cup size is, let's say, 52. I'd use a 50 cup to try and ream the head a little bit, or a 48 cup to ream the head. That gives you the shape that's required to actually then osteotomize the head. So if you ream out the head with a 48 cup, or with a 48 reamer, and then you split the head into two parts, you'll get a fairly wedge-shaped kind of a structure which fits perfectly on the defect, and that you can screw and plate as required.
Yes. Actually, the question was from Akash that nowadays there is a big controversy between the augments and autologous bone graft. So many literature are coming in favor of these augments. So that was actually the question. I think, is it correct, Akash?
Yes, yes, yes.
Yes. So that is
Sure.
what he was actually asking. Maybe Dr. Krishna would
He's
have.
not here.
Yes.
Krishna, Kishore, let's now it's time.
Stop. Yes, sir. So the final word from you, and we'll stop.
It's not final word. It's a good beginning for us in AOPAS as an association that we have started the academic meeting once more. And I would certainly like to thank the international faculties and the speakers who have given willingly their time and the academics and the experience to be shared with all Indian people and the near neighboring countries who have been participants and participating in this webinar. We would like to be continuing with these academic sessions because it's of a great help to listen to the experts from all over the world. And we hope that they will be willing to participate in the future as well. As we said, we have got this thing in our library of our AOPAS association, where all the people who want to have a look can go back anytime when they want and look at the cases or the talks and the discussions which have been held, which will be helping them in their experience and managing people. Ultimately, everything is being done for the benefit of the patient so that we can treat them and serve them better. And for that, I would like to thank all the people, especially the participants, the faculty, and most importantly, Kishore, who has taken the lead in this to start this webinar, was able to, and he has single-handedly done entire webinar right now, as well as the pre-handling of all this, calling the faculties, ensuring that we are getting the Zoom and all the other problems and the anticipation hurdles which anybody and everybody faces. Would like to thank Kishore Panda a lot and for starting and keeping the flame high of AOPAS and academics. Thank you once again for everyone.
Thank you.
And good night to the people in India.
କଲ୍ କରିଛନ୍ତି ସେ ଏବେ ଅନ୍ୟ କଲରେ ବ୍ୟସ୍ତ ଅଛନ୍ତି ଦୟାକରି ଅପେକ୍ଷା କରନ୍ତୁ କିମ୍ବା କିଛି ସମୟ ପରେ ଚେଷ୍ଟା କଲ୍ କରିଛନ୍ତି ସେ ଏବେ ଅନ୍ୟ କଲରେ ବ୍ୟସ୍ତ ଅଛନ୍ତି ଦୟାକରି ଅପେକ୍ଷା କରନ୍ତୁ କିମ୍ବା କିଛି ସମୟ ପରେ ଚେଷ୍ଟା